So we're going to make this very practical, but what we must understand first is a couple of things. What is the laser going to do, and what are we treating? Now, Achilles tendinitis is just a bit of a covering term for, you know, something wrong with the Achilles tendon. And in my own experience and in my practice, I really don't see many cases of Achilles tendinitis, because what it is just an acute inflammation. The tendon has been overloaded. It's a very acute injury. There's been a few fibers injured, and these have to repair. What's going to happen is, when you have this injury, you have a massive cascade, inflammatory cascade, which is the big source of pain in this. The prostaglandins, the interleukin 1, B, the interleukin 18, and this is where we get all the pain from, largely, on top of the micro tears in the tissue and the bleeds. And the laser will have a fantastic effect on this, and we'll go through the settings we would use just to use on an acute tendinitis. However, most of the time we're seeing something quite different, which is a tendinopathy. And a tendinopathy is not an acute injury. It's a degenerate tendon. It is a tendon which has become deformed, which has got the tenocytes, which should be long and thin, have become big and round. The collagen has been, the matrix of collagen is all haphazard, laid down like this, doesn't have its tensile strength. And it's one of these things which is really thickened and very painful. But the question is always, where is this pain coming from? Because if you did a biopsy on that tendon, you wouldn't really find many prostaglandins, which is going to be the big sign of an inflammatory cascade. The prostaglandins aren't there. Where's the pain coming from? Well, a lot of research, Nicola Mafuli, Hakan Alfredson, they hypothesize that the pain is actually coming from a neural ingrowth, whereby when the vascularity has been happening as it keeps on repairing itself and breaking and repairing itself, you get a neural ingrowth, and this is where the pain comes from, and it's not from the prostaglandins. So we've got to go back to ask ourselves, how can the laser really help in this situation? Because what does the laser do? Well, the laser does a number of things, and incredibly well, but it's got the two widths of light hitting the tissues at exactly the same time, 808 nanometers and 905 nanometers. The 808 is sent in at between 1 and 3 watts, depending what the frequency of the hertzing is. The 905 is sent in at 25 watts. What's happening is the 808 is doing 3 different things. It starts a protein synthesis, which starts the tissue repair. Fantastic. We've got either acute injury, some torn tissues, or we've got the deformed degenerate tendon. We're going to reform this, remodel this tendon by filling the cells with ATP, which is created, which will start a natural process in the body, and you'll get a repair situation going in. At the same time, what it's doing is it's causing a massive reduction of inflammation. Now, we're not stopping inflammation because we need some inflammation in repair, but the big problem is with all these injuries we have is the pain we get from inflammation. It puts people into avoidance, stops them doing what they're supposed to do. However, what we know in a tendinopathy, there probably isn't so much prostaglandins, so probably not so much inflammation. What the laser does is it actually it inhibits the interleukins. It reduces the pain from the inflammation, because it reduces the inflammation down to a level which is required just for repair and no more. And a lot of the work in inflammation has been seen with Scott Sigmund on his COVID-19 trials, where he was reducing the inflammation in the pleura of the lungs by huge effects, huge amounts. The third thing it does on the 808 nanometers is reduce edema, and it does that depending what sort of if we're getting more hertz in there, we're getting more of a mechanical effect. and we can actually flush through the fluids in the body. But what comes back to this, in a tendinopathy, without too many prostaglandins, what is the use of the inflammation thing? Well, it comes back to the other thing which I tell everybody about physiotherapy. The machine is there to help us and use an adjunct. What we need to do is we need to stress the tissues, and that's why so much of the exercise programs we give are so important. Because if people don't do that, they're not going to really get the changes that they require, because we need to stress tissues in the correct manner to make the changes we want. And in a tendinopathy, the thing we need to do is an eccentric loading program. Eccentric loading, we're pulling the collagen apart, we're breaking it down, and we're causing a new little bit of micro trauma. Hence, this is where you're going to get a new inflammatory response. The problem being is with the tendinopathy, if we do the eccentric loading, first of all, people won't normally do it because it's too painful. But secondly, if we do it, we're starting a new inflammatory process where we're breaking the tissues, and therefore there are new prostaglandins on top of the already devastatingly painful neural ingrowth that we've got in there. So you're thinking, well, how can we get around this? Well, I like to crack a few eggs with one big stone. And what we're going to do is we're going to actually look at well, first of all, just look at treating a tendinitis and then probably a tendinopathy, but using it while we do an eccentric loading program at exactly the same time. So let's have a look at the patient comes in. The patient has got an acute, just an acute tendinitis. What are we going to do? It's very, very simple. We can just put really what the power that the machine suggests, because it always suggests more at an acute, subacute level, the amount it puts in. What we must remember as well is always, please, if you've just got the MPH5 and you don't have the Charlie head, do the two things. First of all, scan the surrounding tissues with the scan setting, and then we go into the pathology setting. So always global approach and then the pathology approach. So the patients come in just running around yesterday, sharp pain in the Achilles. They've come in. What are we going to do? Well, we're going to do this. Very, very simple. So we're going to get our, we're going to get the computer, the laser, and here we go. We've got on number one, which is the hand piece, because we don't have the Charlie head. I do have the Charlie head. We'll show you what we can do with that later. But if you're going to do the Charlie head, press on that. Otherwise, if you've just got the MPHI, you won't even see that. It's going to let you set for what you want. Okay, so we go on here. And we're not going to go on the pathology. We're going to go on a quick scan. Okay, so we're going to scan. It happened yesterday. It's acute. I'm going to leave it there. Obviously, this would affect all the levels here. 500 hertz, 75% acute. 300 hertz, 25%. So that's fine for me. That's all I'm going to do. The patient is white. If they're black, it's B. If they've got a very good suntan, they're still white. Just use your sense on this. I'm going to press start. I'm going to put my glasses on. And I'm going to check out the patient. And I'm going to get in and start treating this. Okay? For the scan, very, very simple. We're literally just going to scan over here. I don't know if you can see, I do have my glasses on there, you see? Right, now, we're going to scan over the whole of the gastroc, all the surrounding tissues. If you remember, it was just 4 minutes. It's not very long at all, but that's what we're going to do. And over the Achilles as well. And back and forth. I might even just come down round the foot a bit. Again, got the perineals a bit. And that goes on for 4 minutes. Right, to save time, because we've got an awful lot to get through, I'm going to stop it. And I'm going to get, stop, there we are, and I'm going to go and just change it to the pathology settings. So if I can just come back onto here. Right, we've just done the scan, that's finished. Okay, we come off here. We're going to look at the Achilles tendinitis. Now, the settings, as I told you, are very much for the acute, subacute area. And in this case, it would be a tendinitis, and there'll be lots of prostaglandins, and this will work very, very nicely straight away. So it's saying 700 hertz, 7 minutes, 50%, 6 points. It literally was yesterday, so I'm not thinking I don't need any more power. We can get more power if we go into 75%. The more chronic it is, we would go up. But at this moment, I think it's just very acute. I'm going to leave it at that. Sorry, that's not down. I'm going to leave it on 50%, press start, and we go back to treating this. What we're going to do is we're going to get onto the points around here where it's really sore. 6 points, and you can probably see I've got that going there. And you don't need to worry about how long. The machine will stop it when it's ready, okay? Now, what you would say to a patient in this situation is, when we're dealing with soft tissues, we want these tissues moving. So I'd suggest to the patient, could you move your foot forwards and backwards? That's right, yes. Nice and gently, like that. And we're getting the tissues moving. Keep it going. While we're doing this, okay? I'm just going to go for the first one, and I'll show you that we just move it because it will stop itself. You don't have to do it so hard, just nice and gentle. You might get a situation where the patient is in an awful lot of pain, so much that they don't want to do it actively, and then just do a little bit of passive work on here, which helps it. Okay. Now, if it's 7 minutes and 6 points, it should be about 1 minute 10 each spot. And it stopped itself, you've already heard it beep. And I'm going to move to the next bit and then onto here. And then we get it just moving again like that. Now, just a very straightforward Achilles tendinitis, okay? What we could do to save a little bit of time is, stay there, Francis. What we could do to save a little bit of time is we could use the Charlie head if we have the Charlie head. And the Charlie head, we could use that for the scanning area, for a large area, and we could do the pathology at the same time. So just to show you what I would do for this, I would get on, as I've got the Charlie head, I will show you how to use this. That's not that. Okay, what I'm going to do is I'm going to do the scan with the Charlie head. So I'm going to go onto the Charlie head, and I'm going to go on here, and I'm just going to use the muscle contraction. Is there a muscle contraction here? Blah, blah, blah. 2. I'm just going to go on to this muscle contraction there. Okay, so it's let's say it's still an acute situation. I'm not going to change any of this. I'm now going to go start, and I'll show you what we'll do with the Charlie head as well as the handpiece. So I've done that, and then what I'm going to do is go on to 1, press on here. Achilles tendinitis, as we were doing before. Going to leave that exactly as it is. I'm going to press start. And this will obviously save you another 4 minutes because you're not doing the scan as well. So what we do now is, let's just go back to the patient. Okay. And what I'm going to do here is I'm going to get the Charlie head over this area down here. I'm going to get that on. Hopefully you can see that. And now I'll be working around here at the same time on the handpiece. Okay, and I'm doing the spots there. Now I know it's going to go for 5 minutes, so I'll probably move it down. I can move this around as I want, and then this will stop when it's ready, and then I'll move to the next spot and go like that. Okay. Right, let's stop that. Let's stop this, and come back into here. Right, hopefully that made sense. That's how to use the Charlie head and the handpiece at the same time. Now, we've got the problem here where it's a tendinopathy. It is chronic. We need a lot more power in there. How do we do that? Well, we can. I'll just show you on the just using the MPHI, just the handpiece. Let's come back here. Right, on the handpiece, let's just show you what's happening here. We've got the Achilles tendinitis. Okay, 700 hertz, 7 minutes, 50%, 6 points. It's delivering 6.69 joules per square centimeter. We have a tendinopathy. I don't think that's going to be anywhere near enough power. So what am I going to do? Let's go up to 75%. It's going to be 9.76 joules per square centimeter. I still don't think that's enough. I'm going to go up to 100%. 12.82 joules per square centimeter. That's giving me quite a lot of power. So let's say I use that, and then we didn't have the benefits we really wanted. We didn't get the changes we wanted. I think I need more power in that. How am I going to do that? Because I'm already at 100%. Well, it's very simple. We use the magic little button down here, the CPW, and we can go up here. From 12.82 joules per square centimeter, if I press that, it goes up to 26 joules per square centimeter. And now we're talking a shed load of power, and that's going to be more than enough. That might be a little bit too much. So what I could do is go back and just say, Achilles tendinitis, go up to 75% and do CPW. And that's going to give me 20 joules. That's somewhere in between. And that'll be worth trying before I go to the 26 joules. Now, when I press that CPW button, you'll see that the frequency box disappears. Look, there's the frequency box, 7 hertz. It goes and it says CPW in there. And then the joules just go up like that, massively. And I think you should all know, but in case you don't really realize what's happening here, let me just explain. And this is why this is such a useful thing to use in a tendinopathy, because we have a hell of a lot of chronicity in the situation. We need probably as much power as we can get here. Right, now, what is going on? As I told you earlier, the laser, the multi-wave lock system, very important to understand that, is sending in 2 widths of light, 808 nanometers and 905 nanometers. The 808 nanometers is between 1 and 3 joules, depending on the frequency, etc. And the 905 is 25 watts. That is going to cook you and burn you if it wasn't controlled like it is. Because what it is super pulse. So nanosecond on, nanosecond off, nanosecond on, nanosecond off. Just use heat, cool, heat, cool, heat, cool. So you don't get the burning, but you gain the power in there. What we must understand, the amount of power that's going into the body in photobiomodulation, in laser, is calculated in joules. It's the easiest equation in the world. It's watts times second. So we've got one lot giving 25 watts, nanosecond on, nanosecond off. The other thing giving between 1 and 3 watts, okay? Now, what you have to understand is the 808 is on a frequency, generally as a default on a frequency. So it comes on, and it's on for a long time, really, in the real world, because a nanosecond is a millionth of a second. Here it comes on and then goes off, and then comes on and goes off. And this is exactly what is happening. And I drew this the other day, drew it today actually. So you'll probably see on here, this green line is the 808 nanometers, which is off. Okay, it comes on and goes off, and it comes on and goes off, and it comes on. This is all depending on the frequency, and goes off, comes on and goes off. Right now, the multi-wave locked system, this is the important aspect of the whole thing about the laser, is what it is. It's multi-wave, 2 waves, and they are locked. They are completely 100% synchronized. So what happens is when this, on the, whatever the hertz setting is, when the 808 nanometers comes on, through it goes the 905 while this is on, going crazy at a millionth of a second, on, off, on, off, on, off, like that. Then everything goes off, and then it comes back on, and it goes crazy again, all on the tissues. Then it goes off, comes back on, it goes crazy while it's on, everything goes off. Right, watts times second. So you know what the watts is here, you know what the watts is here, and you know how long it's on the tissues for. And that gives you your joules per square centimeter. Right. When I press that CPW button, this is basically the FPW, frequency. So it's frequency on for that long, then off, and then on and off. When we press the CPW button, it just affects the 808 nanometers, but what happens is it becomes continuous, okay? So here we have, I press the CPW button, and it comes on, and it stays on, and it stays on, and it stays on till the time is up, okay? Consequently, the 905, which is locked into this completely 100% synchronized, starts going crazy through here all the time. It doesn't switch off, it goes right through it for the whole time. The photobiomodulated light is on the tissues for so much longer. Watts times second, that's why your joules go over double by pressing the CPW button. And in a very chronic area, a very chronic situation, it is a fantastic thing to use because we're getting so much more power and it will help. But the other thing, just consider what we're talking about. In a tendinopathy, there aren't so many prostaglandins because it's a deformed tendon. There generally aren't. But what we want to do to try and make the changes which are needed to get our clinical outcomes much better, we need them doing the eccentric loading. And the way we can do that to make it much less painful for them is using a laser, because they're going to start a new inflammatory process, which would normally help. But we can reduce the pain massively, and we can then reduce the inflammation to a level which is required, and we can get the changes that we really want and reduce pain and get the tissues remodeled. Right now, hopefully that bit of a ramble makes some sense. It should do, because what we're going to look at now, we've got 10 minutes left. Let's look at a patient who has got a tendinopathy. They have had this for a year now, and they've only just come to see the physio because, like a lot of people, they just don't want to spend any money, and they don't want to, but then think it's got so bad they need to do something, and they've got a massive bulge in it and it's killing them. And they get up in the morning, they can't walk for about an hour because the pain is so bad and it's so stiff. So they come in, it's very simple. I tell them, you have a tendinopathy here. We are going to treat it. How are you going to treat it? We are going to treat it with the MLS laser. Right. It's a nice little thing which you can do. You don't need the Charlie head, but I'm going to show you with the Charlie head to start with. Then I'll show you with just a handpiece if you've got it. But what we're going to do is we are going to get the patient. Well, actually, first of all, we'll get the patient in a second. What I'm going to do is I'm going to get the setting on here. So I'll set both bits up for the tendinopathy. So we can do this really quite quickly, get everything done. Okay, right, so I'm on the just a handpiece. We'll have done a scan first, but now I'm going on to the pathology. Okay, and Achilles tendinitis, but this is not a tendinitis. I'm going up 100%. And actually, do you know what? I'm going to give it the full metal jacket here. We're going in here. I'm going 26 joules per square centimetre. 6 points. That's what we can do. Right, and I'll start that. And it will only get going when I press the button on the handpiece. But I'm going to start with the Charlie head because I want to show you this. Okay, so that's from previously. Right, we're on the Charlie head now. Okay, we go in here, we go on the tendinitis, and it's 7 minutes, 50%, we're going straight up. This goes up in not 25% at a time, it goes up in 50%, so I'm going up to 100%, that's what I'm going to do, and I'm going to go CPW here. I'm going full metal jacket again, loads of joules in there, and what we're going to do is we're going to press start. Okay. Right, we're going to start our eccentric loading program. Just to make it clear to everybody, your eccentric loading, if you can get up on here, we will do it 3 lots of 15, 3 times a day. On the 3 lots of 15, we're going to do 3 lots of 15 with the knee extended, and we'll do 3 lots of 15 with the knee flexed, okay? So can we just do one with the leg straight? Just if you just up on this leg, and okay, just down to here, leg straight please, leg straight, and take the weight on here, don't let it come down here, and then just all the way down, okay? And there's our eccentric loading, perfectly done. Come up on this one, up, okay, no weight on there, weight back onto here, leg straight, and then slowly down. Okay, so you probably have to teach them how to do the eccentric loading first, but what I want to do now is I want to apply the weight. So can you just come and doing that? Just start your loading. Right, up on the right leg. And over onto the left. And then come down. And hopefully you can see what's happening here. Up on the right. And then weight onto the left and then down on the left. Okay, and up on the right. And then weight on the left and slowly down. And up on the right. And then weight on the left and slowly down. Okay, and we do that for the period of time that goes on. There'll be 3 points, so we'll be on behind, we'll be on that side, and they'll be on that side. Okay, so I'm just going to stop this, stop the Charlie head, because I did say I would show you what I will do in exactly the same situation with that handpiece. Just going to stick this back on here. Okay, up, and you probably see, I'm going to switch on, and up, and weight onto there, and hopefully you can see what's happening here. Up on that, and weight onto the left. That's great. There'll be two, it'll stop when it's ready, and we'll go on to the other bit down here. Okay, keep on going. Up. And when that stops, we'll go on to the bit on the side. Okay, do that. Up. Weight on there and down. And up. And down. Okay. And so on till we've done the 6 points. And hopefully we can reduce the pain as we're doing this and make this possible for them to do. Once they find that they can do it without terrible pain, you'll find that they will actually do this stuff at home, which they need to do to get the changes that we want. Right, let's come back. 3, 2, 1. You're back in the room. Okay. Right. Steve, it's about 1:45. I was a bit of a rush through, but hopefully that made some sense to people.
Oh, I'm sure it did. Lots of information there. I got a couple of questions for you, but yeah, no, it absolutely did. I'm sure. As I said at the start, some people seeing the laser for the first time this evening, others that are using it very successfully, and I'm sure they've taken something from that this evening as well with the loading introduced especially. So when you were talking, something across my mind, you were talking there, you wanted a little bit earlier. There's two parts to this question, actually. When you wanted to get more, you went to the CPW, you want to get more joules in there because, the settings took it up to 12 point something joules, I think, don't quote me, but something like that. And then if you didn't, you mentioned if you weren't getting the results you were hoping for at that point, you can then go to CPW and really crank it up, go full metal, I think was your phrase. When would you decide that you were getting those results? Is it when you see them in 2 days' time, or would you think, actually, I was expecting a better response here and now?
No, you can speak to the patient at the time. They might not feel anything immediately, but just say, look, keep me in touch for the next 24, 48 hours.
Okay.
And then it's just having a protocol with them, with the patient, seeing, are they seeing any difference? Now, generally, I prefer to actually not go full metal jacket straight away for the very simple reason, if you put far too much power into a tissue and it's not ready for it, you can get a rebound effect. If it does happen, it's not too bad. They might feel slightly worse, but then that just tells you you've been a bit silly and you put too much power in. And it could be because you can see I can go from 6 joules up to 27, 26 and a half joules just by pressing a couple of buttons. I can send in a shed load of power. And the settings which are put onto this machine are very carefully worked out in the University of Florence, and they're very accurate, but they are for an acute pathology. Yeah. My patient has come in, they've had this tendinopathy for a long time. I've got to be, if we play it more on the safe side, we say, look, okay, let's go up to, start on 50%, let's go up to 75%, or if you're a little bit edgy, go to 100%. We know it should be all right. If it is all right and they say there's no problem afterwards, to say, yeah, well, I haven't really felt much of a change, then, okay, we need to put a bit more in. Yeah. And then we could go down to 75%, CPW, bring it up another level, yeah. Try it with that. And they come back and say after 2 days, they said, wow, yeah, I really am feeling this. Then let's stick with that. Let's leave it at that. If they come and said, no, just not feeling anything, say, right, okay, pal, here we go. And 100% CPW and stick that in them. Yeah. And they say, hold that, mate, and see what they say. Yeah.
And just brilliant. Thanks, Paul. That's great. And for some of the guys out there that may be hearing the phrase rebound effect for the first time, that's where sometimes that's purely where we put too much energy in there initially. So you say, be cautious to start with, go with the settings, and if we have put too much energy
don't panic too much. If you do get a rebound effect, Steve, you always just say to the patient, look, don't panic. Within 24 to 48 hours, it will be back to where it was before. Do not panic. It's a bit like, someone was saying acupuncture. It will be. I guarantee you it'll be back within 48 hours, back to where it was before. Actually, it might be a little bit better after that because it's having the photobiomodulation is having an effect, but in a very aggressive way, and that's why you felt a bit worse to start with.
Yeah, brilliant. Thank you. And I think it's fair to say, and our AZ Laser superstars out there in the audience this evening, hopefully will back me up on this if they will. But you don't see that very often unless you are really stupid and put in too much energy every time. But you don't see that typically very often. It's quite rare, and as I say, it's not a big problem. It's not a problem at all if it does happen. So that's great. But no, that's good to get an understanding of how soon you expect to see the results, and then if you change your protocol on the next sit-in, if you will. So that's really good to get to hear. The other part of the question is, or maybe a separate question entirely, really. You were talking about the handpiece and the ultra head. So again, for those of you out there, we refer to the units as the MPHI, that's MPHI, and then you've got the MPHI5, which is essentially the same unit with the handpiece plus the ultra head, or you may have heard Paul refer to it as the Charlie head. It's the same thing. It's that ultra head that he had on the arm, and then he held it in his hand at the end bit there. Paul, with with that in mind, the main benefits of having an ultra head as well as the MP, are you saying it's purely the times, it reduces the treatment times, or the benefits of throwing in two bits at the same time, for want of a better phrase?
No,
On the
I've lost the other camera which I want. Okay, you probably, if I go back in here, you probably see the Charlie head there. So that the laser here and the Charlie, you get the trolley with the handpiece with the big Charlie head up here. And all that Charlie head is actually is 3 of these things, but they're round, separated, and they're synchronized to hit the tissues about 20 centimeters off the away from them. So it'll cover a big area. So it is phenomenally useful. You'll often find that the power which is going through the Charlie head is higher because you lose a little bit of power with that medium of air in between. That's why, if you want to know why some of the settings are a little bit higher, that's what it is. What's the advantage of the Charlie head? Well, yeah, of course, there is the time thing. You could do one of the things, you know, like the global approach with the Charlie head whilst you're doing the pathology with the handpiece. I often find doing the pathology with the handpiece is I try and do that as much as possible because I find it, I feel that's really getting in sometimes into the places we want because we put that right on the tissue. And if we're doing it on a joint, we're opening up the joint. If we want to get in here, opening up the joint, looking for the optical window. Whereas as opposed to we're moving it if we're doing a soft tissue, when we're doing the joint optical window, that's what I'm doing. So yes, you can save time by using it as the scan, but you can also do it set it completely independently. So you've got the fellow with the Achilles tendon problem, but on his other leg, he's got a massive knee arthropathy, real big problem. Set the Charlie head to work on the knee, completely different settings, as much power as you want, and then work on the Achilles with the handpiece, and you can do it exactly the same time. So you're dealing with 2 completely different pathologies in 2 different ways at exactly the same time.
Brilliant, thank you. And I'll just stress to everybody out there again that it's the same unit that you're buying. You can add the ultra head. There's 2 channels for that same unit. So if you buy an MP5 or if you have an MP5, you don't have any more of an under the bonnet. It's no more powerful. It's the instrument, i.e. the handpiece or the ultra head, that's chucking out the more power. So so that's just to stress that, really. No, thanks for that. That's really good to understand. Thank you. Let me check if I think I did have a question come in. I've not read it. Here we go, from Stella. Hi Stella, thanks for joining us. Here's a question. So I'm struggling with moving the head over the skin, particularly in the hot weather. Any tips? Oh, that's a
I know what she means, actually, because sometimes if we're doing the scanning and it is very, very sweaty, then it can sometimes stick a little bit. You can hold it just above the tissues, okay? That requires a steady arm and you'll move much quicker. You lose a tiny bit of power, not enough to really, it's really insignificant in a way, but you do lose a bit. That's why when we're doing biostimulation, we want to get between 1 and 4 joules. That's what it's very strictly have to be between there. Yeah. The machine always comes up at 2.9. And I think that's quite clever because we know it'll be 2.9 joules, even though we're scanning. If we do a repeatable scan and we move at the same speed, we know each area is getting about 2.9. But we don't, if it's an ulcer or something, for infection control, we don't want to be sticking the head on the tissues. So we always leave about ½ centimeter to 1 centimeter off the head. We know we will lose a bit of power in that, but we're losing probably about 0.3, 0.4 of a joule with that distance, which means your 2.9 comes down to about 2.5, 2.6, which is still exactly between the 1 and 4. perfectly, and so we got no problems, and that's the perfect level we want to get the power onto the tissues. So yes, on the scanning, I know exactly what Stella means. It can just get, you know, well, that's all right. If I would actually come on this bit, yeah, it can get a little bit sticky. So just come really off it. Just you can virtually just touch it, but don't put any, you know, just literally over there, hardly anything at all.
Okay, that sounds like a good workaround. The good news is we only have this weather a couple of weeks a year, so that's fine.
Well, a couple of days. Yeah.
Well, it does feel extremely hot at the moment, doesn't it? But yeah, no, thank you, Stella. I hope that helped you there. Thank you. And we've got another question come in from Hugh. Thank you, Hugh. Thanks for joining us. Thanks for the question. Are there any, I don't know if you will know that, well, actually, I'm sure if anyone does know this, you'll know this, Paul. Are there any studies in the peer-reviewed literature comparing the efficacy of laser compared to shockwave for Achilles tendon problems? The S word always gets brought up.
Well, the best bit of evidence is if you'd seen the British Lions team, which has been selected today, Anthony Watson has been put on the wing. Anthony Watson did have shockwave treatment on his ruptured, he had his ruptured Achilles, he had the repair. He then was going to rehab and he had the shockwave. Again, I don't want to say anything against shockwave, because shockwave does work. It's very good, but this comes back to what I've been trying to do here today to show you a way of using the laser. Shockwave works, yes, the science is there, but it has two major problems. It's only useful on very limited amount of tissues, which are really collagen structures. But the other thing is, this is the most important thing. It is not really well tolerated, because what you're doing is you might as well get a hammer and start hammering in somebody's Achilles tendon. What are you trying to do? You're trying to break it down to start a new inflammatory process. And so that is exactly what the heavy eccentric loading program is doing, except we're not just using a hammer. We're using their weight or even a rucksack on the back, which as they work it, as it gets longer, it starts pulling the collagen like that in a very controlled manner, but it starts doing exactly what shockwave's doing, which is breaking down micro trauma in the tissues so it can repair again. Right now, here is the big problem. The laser is doing something completely different to the shockwave. The shockwave is initiating a brand new massive cascade, inflammatory cascade, to try and get the new repair going in the right place. Because on a tendinopathy, it's all been laid down like that. It's a mess. It's swollen over like that. Smash it with that shockwave, breaks it down, and then we should still probably do our eccentric loading, and we start getting it to go like that, and we get its tensile strength, and it repairs, remodels. What's happening is there are too many people who are unable to do the eccentric loading, which they need to do, because they have just said, right, that is it, I've had enough of pain. Because the fellow went in there with his big gun machine, he beat the shit out of me, it is killing me, and now he wants me to do 3 lots of 15 on the thing like that. He can forget it, not for me. Right, what we're doing with the MLS laser is we're breaking the tissues down. I just showed you a way of trying to do this much quicker, because you can get them doing this. And as they're doing this and breaking the tissues, starting a new inflammatory response, we're putting the laser in there, which is controlling it. You see, after they've used MLS laser on all these subjects, what they find is a massive increase of NLRP10 proteins. Now that is a sure sign that what the NLRP10 protein does is that controls the inflammatory response. It actually reduces this massive cascade of interleukin 1, interleukin 1b, interleukin 18, and actually it says, well, come back here, and it stops that. So the inflammatory process is actually kept in control. Therefore, pain is much better control. And so I don't think we need to hurt people more than is necessary. That doesn't sound right, does it? We don't need to hurt people. So why don't we just make it much easier that we're going to get them doing this eccentric loading and reduce the pain massively. Bringing on the Anthony Watson thing, Anthony Watson had it. He re-ruptured his Achilles tendon. Then he actually found out about the MLS Laser. He got in touch with us, and then we started using the MLS Laser on his twice ruptured Achilles tendon. The man is back faster, quicker, better than he ever was. And he loved it so much, he bought his own. He's a bit like, who's that fellow from Remington? I like the company so much, I bought it. Okay, we didn't buy the company. But he's got his own MLS, which he uses, and it will be with him now in South Africa. Yeah. If they have a shockwave, you can use the laser in conjunction with the shockwave. So you've smashed up the tissues, but then by filling the cells with ATP, you actually start the natural repair process. So you speed that up, and you reduce the pain, and you reduce the inflammation. So you're using both the shockwave and the laser to monumental effect.
It's that's a good point, actually, and for everybody out there may not be aware, we've got a number of users of the laser that have shockwave as well, and they report back some really good results. We favor laser over shockwave, of course we do, but it doesn't have to be one or the other. They can work really well together. Not everybody can afford to buy two, of course. I appreciate that, but the laser gives you far more flexibility. We're talking specifically on Achilles tendinitis this evening, but if we wanted to go into other conditions, there's so much that you can treat with the laser that you can't with the shockwave if you can only afford, if you can only got room for one modality in your clinic. And Leon's got another question: is one treatment a week sufficient for chronic Achilles tendinopathy?
Is one
treatment a week sufficient?
You're going to go on longer with a really chronic with a really chronic, I could say you could, with a really chronic tendinopathy, Achilles tendinopathy, you could be going for 6 to 8 weeks, I'd say.
Once a week, but if you were to see them 3 times.
Oh, yeah, sorry, yes, yeah, you could, yeah, that's fine, yeah.
If you just, so if you were doing it weekly, then the accumulative effect is going to take a longer number of weeks to get the result.
What I would always tell anybody,
more. If you saw them more initially, you wouldn't.
I think it would always help because you can get more work done. See, what I would tell people, if you're doing the eccentric loading, they're limited to a certain extent by the pain. We can reduce the pain massively, and especially in the early stages, that was when it would be best to do more of it, because your eccentric loading program, on top of the problem you've got, as I said to you before, you're starting a new inflammatory process. So you've got double whammy of pain. You've got the prostaglandins, new prostaglandins, and you've got your neural ingrowth. What happens is, and that's why I say at least 6 to 8 weeks, because if you do your eccentric loading and you stick strictly to it 3 times a day, 3 lots of 15 with the leg straight, 3 lots of 15 with the knee bent, and you're doing it, and then you start progressing the weight on there, people will say to me after about 3 or 4 weeks, this is killing me. It's really not, I don't feel it's getting any better. I say, okay, it's 4 weeks. Give me 2 more weeks. Give me 2 more weeks maximum, and then you tell me it's not working. And they come in the next week, probably 1 week later, say, do you know what? I think I've turned the corner. Because what happens is suddenly the remodeling really takes place. The inflammatory levels have come right down, and we can bring that down much quicker with the laser. But that's come down, and the pain is getting so much less because you're remodeling the tendon, and you will see a change in the thickness because it is becoming a nice tendon. The tenocytes, which have become big and round, have gone back to long and thin, which is reducing the thickness. And that's all part of the process of this eccentric loading, because other proteins called integrins start flying between the collagen and the cells, start knocking on the cells, which hits the cytoskeletons, the things which are holding the cells open. That starts knocking on the nucleus of the cell. That starts the protein synthesis. And this happens really incredibly quickly. As I say, 5 to 6 weeks. And if you could actually do more laser in that very first 5 to 6 weeks, you'd actually get a huge change. Because literally after that, you might not need to do it too much because they will be out of pain, but you will still say to them, carry on your eccentric loading. You're not out of the woods yet because you're still remodeling, but the pain might have gone and everything looks so much better. Still carry on for another 4 or 5 weeks. So that's what I would say.
Thank you, Paul. I hope that helped, Leonie. Thanks for the question again. Thanks for joining us again. As I say, I know you're doing incredibly long days and weeks at the moment, so great that you joined us. Don't think we've got any other questions coming yet, or now.
Good. Good. I'm going to go home.
That was great. Yeah, thanks, Paul. Let's do that. Let's let you and Francis get home safe. Thank you ever so much again. Thank you to everybody out there for joining us. Thanks for your questions. Hope that was of help. As I say, just to underline again, so you AZA laser superstars out there, hope you took something away from that you can keep improving what you're doing with the laser. For those of you that are not an AZA laser superstar yet and want more information, then you know where we are. Just drop us a line. If you could all like us and big us up on any social media platforms that you might be on, we're always grateful for that. As I say, the CPD this evening is completely free. Just in return, if you've liked it, tell everybody that you enjoyed it, and we'd be very, very grateful for that. So Paul, you go home. Francis, thank you ever so much indeed. Really grateful to you both. Home safe. Enjoy the rugby at the weekend, and we will see you soon. I'll speak to you soon, and we'll see you on here in the autumn.
Okay, hello's okay, everybody. And Francis, you can't be seen there. You have to come around here. So Francis, wave bye-bye there. So Francis, wave.
There she is.
Right, we're both waving bye-bye. See you guys. Thanks a lot. Bye.
Good night. Thanks, Paul.